Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 323 of our pharmacotherapy series, which majors in diabetes mellitus. The first question reads, RPA is a 43-year-old African-American woman visiting a primary care clinic to obtain a routine physical examination for her new job. Her past medical history is significant for gestational diabetes mellitus, abbreviated as GDM. She was told during her 2 pregnancies, last child born 3 years ago, that she had borderline diabetes, which resolved each time after giving birth. Her family history is significant for type 2 diabetes, that is her mother, maternal grandmother, and older first cousin, hypertension, and cardiovascular disease. She denies tobacco or alcohol use. She states that she tries to walk 15 minutes twice a week. Physical examination is significant for moderate central obesity. She is 5 feet 4 inches. She weighs 160 pounds. Her BMI is 30.2 kilograms per meter squared. And blood pressure, BP, 145 systolic, 85 diastolic. RPA denies any symptoms of polyphagia, polyuria, or lethargy. On checking her electronic medical record, she has documented hypertension and a fasting plasma glucose, abbreviated as FPG, value of 119 mg per deciliter, measured 2 months prior. What features of RPA's history and examination are consistent with an increased risk of developing type 2 diabetes mellitus? The features of RPA's history that are consistent with an increased risk of developing type 2 diabetes include her age, ethnicity, weight, family history of diabetes, history of gestational diabetes mellitus, and a documented impaired fasting glucose, abbreviated as IFG. In addition, type 2 diabetes is also often associated with other disorders such as hypertension. The fact that RPA has hypertension that is not well controlled and has a family history of hypertension and cardiovascular disease may indicate that she is predisposed to insulin resistance, further putting her at risk for developing type 2 diabetes. The next question reads, the physician orders an A1C for RPA, which comes back at 6.1%. How should RPA be managed at this time? Both the A1C and fasting plasma glucose values are in the prediabetes range. RPA should be educated about her risk for developing type 2 diabetes. Working with her healthcare providers, RPA should be encouraged and educated on how to institute lifestyle modifications, that is, medical nutrition therapy, abbreviated as MNT, and physical activity, that will help her to lose weight, improve her cardiovascular health, and decrease her risk for developing type 2 diabetes. A weight loss goal of 5% to 10% during the next 6 to 12 months should be recommended, and she should increase her level of moderate physical activity to at least 150 minutes per week. Her hypertension should be managed. At this time, the use of pharmacologic agents, i.e., metformin, to prevent the development of type 2 diabetes is not recommended. The next question reads, P.A.H., a slender, 18-year-old woman who was recently discharged from the hospital for severe dehydration and mild ketoacidosis, is referred to the diabetes clinic from the University Student Health Service. No records are available. A fasting and a random plasma glucose ordered subsequently were 190 and 250 mg per deciliter. Approximately 4 weeks before she was hospitalized, P.A.H. had moved across the country to attend college, her first time away from home. In retrospect, she remembers that she had symptoms of polydipsia, nocturia, that is 6 times a night, fatigue, and a 12-pound weight loss during this period, which she attributed to the anxiety associated with her move away from home and adjustment to her new environment. Her medical history is remarkable for recurrent upper respiratory infections and 3 cases of vaginal monoliasis in the past 6 months. Her family history is negative for diabetes, and she takes no medications. Physical examination is within normal limits. She weighs 50 kilograms and is 5 feet 4 inches tall. Laboratory results are as follows. Fasting plasma glucose is 280 mg per deciliter. A1C is 14%, and trace urine ketones as measured by ketodiastics. On the basis of her history and laboratory findings, the presumptive diagnosis is type 1 diabetes mellitus. Which findings are consistent with this diagnosis in P.A.H.? P.A.H. meets several of the diagnostic criteria for diabetes. She has classic symptoms of type 1 diabetes, that is polyuria, polydipsia, glucosouria, fatigue, and recurrent infections, a random plasma glucose greater than 200 mg per deciliter, and a fasting plasma glucose greater than 126 mg per deciliter on at least 2 occasions, as well as an A1C greater than 6.5%. Features of P.A.H.'s history that are consistent with type 1 diabetes mellitus, in particular, include the relatively acute onset of symptoms in association with a major life event, moving away from home, recent weight loss, ketones in the urine, negative family history, and a relatively young age at onset. The next question reads, P.A.H. will be started on insulin therapy on this visit. What are the goals of therapy? Will normoglycemia prevent the development or progression of long-term complications? The goal of diabetes management is the prevention of acute and chronic complications. The results of the DCCT and DCCT-EDIC studies convincingly demonstrated that lowering blood glucose concentrations through intensive insulin therapy in persons with type 1 diabetes slows or prevents the development of microvascular complications. The ADA recommends an A1C goal of less than 7% for most patients, and an individual goal as close to normal as possible, that is less than 6.5%, if it can be achieved without significant hypoglycemia. For children and adolescents, the ADA recommends an A1C goal of less than 7.5%, and an individualized goal of less than 7% if achievable without significant hypoglycemia. It is important to understand that physiologic or basal bolus insulin therapy involves a complete program of diabetes management that includes a balanced meal plan, physical activity, frequent self-monitoring of blood glucose abbreviated as SMBG, and insulin adjustments based on these factors. In summary, P.A.H is a patient newly diagnosed with type 1 diabetes who has not yet developed any signs or symptoms of long-term complications. Therefore, she is an ideal candidate for basal bolus insulin therapy, and if she is willing and motivated, normoglycemia with rare hypoglycemic episodes is a reasonable long-term goal. This goal should be achieved gradually over the course of several months with insulin therapy, diet, education, and strong clinical support. A desirable goal is an A1C value as close to the normal range as possible with minimal episodes of hypoglycemia. The next question reads, what methods of insulin administration are available to achieve optimal glucose control? A physiologic insulin regimen is designed to mimic normal insulin secretion as closely as possible. Problems with insulin delivery include factors that affect the subcutaneous absorption of insulin. Before the development of the rapid-acting insulin analogues and basal insulins, previous insulins lacked pharmacodynamic profiles that allowed one to closely simulate normal pancreatic release of the hormone. In the non-diabetic individual, the pancreas secretes boluses of insulin in response to food. Between meals and throughout the night, the pancreas secretes small amounts of insulin that are sufficient to suppress lipolysis and hepatic glucose output, referred to as basal insulin. Clinicians now have more tools to mimic this basal bolus model. Two methods have been used to achieve this pattern of insulin release, namely A. Insulin pump therapy, previously referred to as continuous subcutaneous infusion of insulin, and B. Basal bolus insulin regimens consisting of once or twice daily doses of basal insulin coupled with pre-meal or snack doses of rapid-acting insulin. Let's briefly look at insulin pump therapy. The use of an insulin pump is currently the most precise way to mimic normal insulin secretion. This consists of a battery-operated pump and a computer that can program the pump to deliver predetermined amounts of insulin, i.e., regular, lispro, aspart, or glulisine, from a reservoir to a subcutaneously inserted catheter or needle. These systems are portable and designed to deliver various basal amounts of insulin over the course of 24 hours as well as meal-related boluses. Most patients using an insulin pump use a rapid-acting insulin, rather than regular insulin. For meal coverage, the rapid-acting insulin can be given 0 to 15 minutes before eating. The delivery of the bolus can be adjusted depending on the type of food eaten, e.g., piece of cake versus slice of pizza. Caveat: if subcutaneous delivery is interrupted, check for rise in glucose and urine ketones after 2 or 3 hours. Because there is no subcutaneous pool, effects dissipate quickly. The preferred meal planning approach for patients using an insulin pump is carbohydrate counting. The insulin-to-carbohydrate ratio, or how much carbohydrate is covered by 1 unit of insulin, must be determined. One method is to use the 500 rule. The number 500, or 450 for regular insulin, is divided by the total daily dose, abbreviated as TDD, of insulin the patient is using to determine the insulin-to-carbohydrate ratio. Insulin pumps are capable of delivering many basal insulin rates. The basal insulin infusion rate may be adjusted depending on the situation. Many patients find it advantageous to decrease the basal rate during the middle of the night when nocturnal hypoglycemia is most likely to occur. The basal rate also may be increased before awakening to avoid hypoglycemia secondary to the dawn phenomenon, or adjusted when physically active, adjustments that are not possible using subcutaneous basal insulin injections. Features of the current pump models include the bolus wizard, which calculates bolus doses based on preset carbohydrate to insulin ratios and correction factors, carbohydrate counts for selected foods, and an insulin on board feature, which helps avoid excessive dosing of insulin by indicating how much insulin from a previously administered dose should still be acting. Most insurance plans provide coverage for insulin pumps for patients with type 1 diabetes and for some patients with type 2 diabetes. Factors to consider when choosing a pump include safety features, durability, ability of the manufacturer to provide service, availability of training, clinically desirable features, continuous glucose monitoring abbreviated as CGM compatibility, and cosmetic attractiveness for the user. The ADA website, www.diabetes.org, contains helpful information about insulin pumps for patients under the Living with Diabetes section. The next question reads, how can insulin be administered to P.A.H. in order to model physiologic release of insulin from the pancreas? Endocrinologists have developed a variety of insulin regimens that are intended to mimic the natural release of insulin from the pancreas. A total daily dose of insulin is estimated empirically, e.g., 0.3 to 0.5 units per kilogram per day for patients with type 1 diabetes. The total daily dose of insulin then is split into several doses. In general, the basal dose comprises approximately 40% to 50% of the total daily dose, and the other bolus doses comprise the remaining 50%. If a patient eats 3 meals per day, the bolus dose would then be divided by 3 to calculate the number of units of bolus insulin required to cover each meal. A regimen much less commonly used in patients with type 1 diabetes involves injecting a mixture of intermediate-acting and regular or rapid-acting insulin twice daily, before breakfast and before dinner. The morning dose of regular or rapid-acting insulin is intended to take care of the breakfast meal. The morning dose of neutral protamine hagedorn, abbreviated as P.A.H, takes care of the noon meal and provides basal insulin throughout the day. The evening dose of regular or rapid-acting insulin takes care of the evening meal, and the evening dose of neutral protamine hagedorn provides basal insulin levels during the night and takes care of any evening snack that is ingested. Because neutral protamine hagedorn is an intermediate-acting insulin and has a peak effect, it does not provide true basal insulin coverage. Also, when neutral protamine hagedorn is injected in the morning, the patient must eat lunch on time because of this peak effect, otherwise, he or she will experience hypoglycemia. Also, when neutral protamine hagedorn is taken with mealtime insulin before dinner, the patient is at risk for nocturnal hypoglycemia from the peak effect of the evening dose of neutral protamine hagedorn. The advantage of using a rapid-acting insulin, e.g., insulin lispro, insulin aspart, or insulin glulisine, instead of regular insulin in this regimen is to facilitate the patient being able to take insulin doses immediately before a meal. However, the peak effect of the neutral protamine hagedorn component in this combined dose still presents the same problems. This type of insulin regimen does not mimic physiologic insulin release. It is the same except that the evening dose of neutral protamine hagedorn is given as a third injection at bedtime. This shifts the time of peak effect from approximately 2 to 3 a.m. to approximately 7 a.m. By administering neutral protamine hagedorn at bedtime, nocturnal hypoglycemia is reduced, and peak insulin activity occurs when the patient is more likely to be awake and ingesting food. This method may be useful for patients in whom nocturnal hypoglycemia and fasting hypoglycemia are particularly troublesome. However, this regimen also does not mimic physiologic insulin release. The regimen that most closely mimics physiologic insulin release besides the use of an insulin pump is the use of a once-daily basal insulin such as insulin glargine, detamir, or degludec to provide basal insulin levels throughout the day, along with doses of a rapid-acting insulin preferred or regular insulin before meals. When smaller doses are used, twice-daily insulin detamir and possibly U100 insulin glargine will be required for 24-hour coverage. Insulins U100 and U200 degludec and U300 glargine will last 24 hours with once-daily dosing. This method theoretically provides insulin similar to the insulin pump, constant basal levels plus small boluses for meals and snacks. In doing so, it offers some of the same advantages of the pump in that it permits some degree of flexibility in the patient's lifestyle. For example, if a patient with diabetes chooses to skip a meal, he or she omits a pre-meal bolus. If the patient chooses to eat a larger meal than usual, he or she increases the pre-meal bolus. Similar dose adjustments can be made to accommodate SACs, exercise patterns, and acute illnesses. Alternatives to this regimen are scenarios where the long-acting insulin is replaced with intermediate-acting insulin for basal coverage and/or the rapid-acting insulin is replaced with short-acting insulin for bolus coverage. These options, however, are not preferred because they do not as closely mimic normal physiologic insulin release. The next question reads, should P.A.H. use an insulin pump or multiple daily insulin injections? Patients with type 1 diabetes should be placed on a basal bolus insulin regimen. P.A.H. is an ideal candidate to strive for an A1C goal of less than 6.5%. She is newly diagnosed, has not yet developed the long-term complications of diabetes, and should derive the benefits of normoglycemia. Assuming P.A.H. will be able to manage a basal bolus insulin regimen, individualized target blood glucose levels that strive for the best level of glucose control possible without placing her at undue risk for hypoglycemia should be prescribed. She must be willing to test her blood glucose concentrations 4 or more times daily and inject herself 4 times daily or learn about the use and care of an insulin pump. She also must be willing to keep detailed blood glucose and food records and participate in an extensive education program that enables her to adjust her insulin doses based on blood glucose concentrations, physical activity, and the carbohydrate content of her snacks and meals. Transition to an insulin pump is facilitated by patients being able to attain these skills using multiple daily subcutaneous insulin injections before insulin pump initiation. The ADA recommends that the use of insulin pumps be limited to highly motivated individuals under the guidance of a healthcare team trained and knowledgeable in their use. Pumps offer the patient the ability to use multiple basal rates during the 24-hour period and assist with the calculation of bolus and correction insulin doses. Most studies have shown that pump therapy provides equivalent and sometimes better glycemic control than does intensive management with multiple injections. Insulin pumps are particularly useful in patients with frequent, unpredictable hypoglycemia or marked dawn phenomena. Others have described the methods by which insulin doses are established and altered in patients using the insulin pump. Because P.A.H. has just been diagnosed, she should be initiated on a basal bolus subcutaneous insulin therapy. Once she has acquired these skills, she may be considered for pump therapy. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 324.